Our next speaker this morning is Dr. Tim Bongartz. He's Assistant Professor of Medicine at the Mayo Clinic College of Medicine in Rochester. He's a native of Dusseldorf, Germany. He received his medical training in Marburg and Munich, where he graduated magna cum laude. Did his internal medicine, rheumatology, and clinical immunology in Munich. And then he was a research fellow at Mayo. He's received a Fellows Award from the American College of Rheumatology. He's got a number of publications, 2 book chapters. And this morning he's going to cover a very interesting topic for us, rheumatoid arthritis treatment and malignancies. How do we deal with the diseases we are or may be causing? Tim.
Well, I really have to thank David McLean to inviting me to this gorgeous location and allowing me to escape from Rochester, Minnesota, which bears a few similarities with Glasgow, Scotland, we just learned about. So when I was walking down the beach this morning, enjoying the sunrise and the pelicans flying by and going through my talk, I stepped into that little oil puddle, this rubber-like oil puddles you sometimes have at the beach. And I thought to myself, given a talk with this kind of title, it's a little bit like this oil puddle, spoiling the beauties that are surrounding us, especially if you're framed by 2 talks by Ian McGuinness about the glorious future we have. So I'm trying to move here, and it doesn't work. Okay, here we are. So what I would like to discuss with you today are mainly 3 things. First, based on our knowledge about tumor biology and immune biology, do we really have to expect malignancies as a main side effect of our immunosuppressive therapies? And second, what are the methodological challenges of detecting a potential association of our therapies and malignancies? And third, what do we know at this point? And is there anything we have to act upon in our clinical practice? This is the abundant industry support for this type of research. So independent of the question whether we're having an impact with our therapy on cancer incidence, we have to acknowledge that cancer will be a very frequent event in our patients. Almost 1 in 2 patients will develop a cancer during their lifetime, and approximately 20% in the population will die from a cancer. So this tells us 2 things. First, there's still a long way to go with respect to cancer prevention and cancer treatment. But second, and more importantly, within the context of our discussion, we have to acknowledge that even with a small shift in the relative risk due to our therapies, we will cause a major shift in the absolute risk due to the high baseline frequency of the event. So I think it is very justified talking about this issue, even if the relative risk might be just small. So getting back to the question, should we expect malignancy as an almost automatic potential side effect of immunosuppression? And should we regard the immune system as some type of white knight that is, protecting us from the evils of malignant growth? Well, if you ask the person on the right side, he would probably answer yes. This is Paul Ehrlich, who was the first one who speculated that there must be a protective factor in our body that is protecting us from a continuous growth of malignant cells. And he actually postulated that this protective factor, this a positive factor, how he called it, must be grounded in the immune system. And he appeared to be a strong believer in the theory. He was smoking about 25 strong cigars per day and always carrying a case of cigars with him, and he never got lung cancer. So there's now, over the last decades, ample evidence that there is significant truth to this theory. We, for instance, know that rag knockout mice who don't have functional B, T, or natural killer cells will develop spontaneous cancers and have an impaired immunosurveillance of transplanted cancer you put into these mice with an accelerated tumor growth. Now, the gentleman on the left, on the right, Rudolf Virchow, whom we regard as the father of modern pathology, had quite the opposite idea. He observed these lymphoreticular infiltrates, how he called them, in tumor tissue, and he speculated that chronic inflammation is actually something that is driving cancer. And it is very interesting to look into the oncology literature over the last couple of years, where you now see ample evidence that the immune system inflammation is actually a driving force of malignancy. So inflammatory cytokines have a significant impact on angiogenesis, for instance, improving the blood supply of tumors, and also promoting cell detachment and thereby promoting a metastatic disease. So, in the context of our topic, we have to acknowledge that the relationship between immunosuppression and tumor biology is probably a lot more complex than we think, and that the net effect of our immunosuppressive therapy will probably be the results of several different forces which may actually be pulling into different directions. Now, in order to get a better idea in which direction this main vector may be pulling, it appears to be a good idea to look at primary immunodeficiencies. And it is very interesting to see that in almost all primary immunodeficiencies, you won't see an overall increase of malignancies. You see an increase of very particular malignancies, such as lymphoma, for instance, lymphoproliferative disease, X-linked lymphoproliferative disease, for instance, Wiskott-Ulrich syndrome, which is associated with a very significant increase in lymphoma incidence. But again, no overall increase of malignancies such as colon cancer, breast cancer, prostate cancer. Now, if you look at another in vivo model of heavy immunosuppression, transplant patients, the same picture. We don't see an overall increased risk of malignancy. What we do see is an increase in lymphoproliferative disease, lymphoma, and skin cancer. Now, if we look at rheumatic treatments with immunosuppressive drugs, usually at lower doses than are used in transplant medicine, again, we see pretty much the same picture. For instance, methotrexate. There is no study out there that has shown that there would be an increased overall cancer risk with methotrexate, but we very well acknowledge that there are sporadic cases of methotrexate-associated lymphoma that will spontaneously regress after withdrawal of methotrexate. Same thing for other immunosuppressive, conventional immunosuppressive treatments we use, such as azathioprine, Cytoxan, cyclosporin A. Increase of very particular tumors, but no overall increase in the malignancy risk. And I think that teaches us something very important when we're looking at side effect and adverse event data of biologic trials. Maybe it's not the right question to ask, is there an overall increase of malignancies? But maybe it's better to ask, is there an increased cancer-specific risk of particular cancers at a particular point in time? Now, what about these new agents? I think we are all dizzied by the expansion of our therapeutic armamentarium. And when you look into the literature or listen to presentations, you often hear these terms: targeted therapies, immunomodulating therapies, immunoediting therapies, somehow implying that we know exactly what we're doing. Well, I think at this stage of biologic therapies, targeted does not mean selectivity between physiologic or pathologic processes. We're still targeting molecules that are part of the healthy, desired immune response and the undesired autoimmunity. And we're potentially unbalancing a whole system with our manipulation that is crucially involved in self-tolerance, defense against microbial growth, and tumor growth. So, assuming that there is a strong necessity for closely looking at the potential that these drugs are associated with an increased malignancy risk, and our knowledge about associations between immune biology and tumor biology tells us to do so, we have to look. And